Chapter 27, Thyroid, Orbitopathy. Concept. Thyroid orbitopathy is known as the ocular involvement of Graves' disease with Saint Eve, spelled as YVES, American, English Ease, and French Eve, with Saint Eve in 1773 and Perret in 1786, being the first to describe the association between toxic goiter and ophthalmopathy. Graves published 3 cases in 1835 referencing this pathology, and later in 1840 Bastow emphasized the relationship between exophthalmos and thyroid disease. The Anglo-Saxons called it Graves' disease. The French used the term dysthyroid orbitopathy, and in other countries it was known as Bastow's disease. Generally, it is associated with states of thyrotoxicosis, but it has also been linked to other thyroid dysfunctions such as Hashimoto's thyroiditis, immune-secreting carcinomas, and even occurs in euthyroid states. The Anglo-Saxons call it Graves' disease. The French use the term dysthyroid orbitopathy, and in other countries it was known as Bastow's disease. Generally, it is associated with states of thyrotoxicosis, but it has also been linked to other thyroid dysfunctions such as Hashimoto's thyroiditis, immune-secreting carcinomas, and even occurs in euthyroid states. Hence, it's being referred to as dysthyroid orbitopathy. It is an enigmatic autoimmune disease of unknown etiology that involves both the thyroid and the orbit, including muscles and orbital fat, needing complex medical treatment in its inflammatory state and surgical treatment in non-inflammatory conditions. Inflammatory state, medical treatment, and in non-inflammatory conditions, surgical treatment. It accounts for 50 to 75% of the consultations in an orbital surgeon's office. The higher the incidence, the more developed the country. It tends to occur in women aged 25 to 50 and in men between 30 and 60, with a ratio of 8 to 2 in favor of females. It has frequency of 1 female per year for every 2,000 women and 1 male per year for every 10,000 men, showing it's more common in females. 85% of thyroid orbitopathy occur in hyperthyroid states, 8% of hypo, and 7% in normo or euthyroid states. In the last 30 years, we have studied 2,720 cases from a total of 4,200 orbits. In the last 10 years, we have found that the incidence of thyroid orbitopathy is 7 by 10 patients with orbit disease. It's more common in females, but it is more severe in males, especially those who smoke. So in this paragraph, we'll see the pronunciations, correct pronunciations. Now there is a name, French name, Saint YVES. YVES. In English it is pronounced as Is. In French it is pronounced as Eve. Then it's thyroiditis according to British. And then one more thing, it's orbital or orbital. So the correct pronunciation is So the correct pronunciation is orbital, not orbital, orbital. Now, epidemiology and pathogenesis. Autoimmune thyroid disease (ATD) has a genetic basis influenced by environmental factors. It comprises a set of closely connected diseases. First, Graves' disease, goiter, hypothyroidism, and thyroid-associated orbitopathy. Second, Hashimoto thyroiditis and euthyroid goiter or hypothyroidism. Third, destructive thyroiditis or myxedema. 3. Destructive thyroiditis or myxedema. These three components of autoimmune thyroid disease share the same genetic predisposition, immunological mechanism, pathological characteristics, and familial cluster, with the same patient transitioning between different clinical pictures over time. Phenotypic manifestations differ only in the immune responses involved. They have the same genetic basis but different phenotypic manifestations. Depending on the action of T lymphocytes, activation of the inflammatory cascade occurs via autoreactive T lymphocytes that recognize thyroid antigens. These activated T lymphocytes synthesize lymphocytes with different actions. If they are thyroid gland stimulating antibodies, helper function, Graves' disease arises when the antibodies produced are blockers. When the antibodies produced are blockers, Graves' disease arises. Or if a destructive process, killer function, occurs, the result is Hashimoto's thyroiditis or primary myxedema. Common features of autoimmune thyroid disease include immune activity against thyroid-specific antigens, mainly thyroid-stimulating hormone receptor (TSHR), thyroid-stimulating hormone receptor, thyroid peroxidase antibodies, and thyroglobulin. The antibodies which are directed against certain antigens in autoimmune thyroid diseases are these thyroid specific antigens, mainly TSHR, that is thyroid stimulating hormone receptor, TPO, thyroid peroxidase, and thyroglobulin, TG. Antibodies prevalence in autoimmune thyroid disease group: general population, thyroid receptor antibodies 0, thyroid globulin antibody 5 to 20, thyroid peroxidase antibody 8 to 27. That was about in general population. Now in Graves' disease, thyroid receptor antibodies are found in 80 to 95% of the patients. Thyroglobulin antibodies are seen in 50 to 70% of the patients, and thyroid peroxidase antibodies are seen in 50 to 80% of the patients, mainly thyroid receptor antibodies, that is thyroid stimulating hormone receptor antibodies. Hashimoto's thyroiditis, we see mainly thyroid peroxidase antibodies, that is 90 to 100%. Then second, thyroglobulin antibodies, that is 80 to 90%, and very less, that is thyroid receptor antibodies, that is TSHR, that is thyroid stimulating hormone receptor antibodies or thyroid receptor antibodies in 10 to 20% in Hashimoto's thyroiditis. In relatives of patients with autoimmune thyroiditis, thyroid receptor antibodies are found 0, then 30 to 50% thyroid globulin antibodies, and in 30 to 50% of the patient's relatives, we see thyroid peroxidase antibodies. These antibodies, along with the homeostasis T3, T4, and TSH, let us know which type of autoimmune thyroid disease we are dealing with. Of all the clinical forms of autoimmune thyroid disease, the one with the highest prevalence of thyroid orbitopathy is Graves' disease. So, thyroid orbitopathy, the highest prevalence is Graves' disease. Graves' disease has a bimodal peak incidence in both men and women, with the average age slightly higher in men. Ocular involvement in the context of EG tends to be more severe and have a worse prognosis in elderly patients, men and diabetics. Worse prognosis in elderly patients, gender men and diseased diabetics, also smokers. Thyroid orbitopathy is bilateral in about 90% of cases, yet asymmetrically so. The possibility of reactivation is rare, occurring in only 5% of patients, but must be kept in mind. Reactivation occurs in 5% of the patients. As mentioned above, the thyroid gland and the orbit are related and both have thyroid stimulating hormone receptors. So, thyroid gland and the orbit are related and both have thyroid stimulating hormone receptor antibodies, that is, thyroid receptor antibodies. Thyroid stimulating hormone receptors of the thyroid are stimulated by thyroid receptor antibodies, increasing the synthesis of thyroid hormones. So these thyroid stimulating hormone receptor antibodies, they join with thyroid stimulating hormone receptors, and what they do, rather than killing these receptors, what they do, they actually promote the or increase the synthesis of thyroid hormones, which in turn stimulates the activation of orbital fibroblasts. So what they cause, they increase the synthesis of thyroid hormones. Then second, they cause activation of orbital fibroblasts. These orbital fibroblasts, they express this antigen, thyroid stimulating hormone receptor antigen, and there these antibodies, they combine with these antigens and they activate orbital fibroblasts. Fibroblasts are part of the connective support tissue of the orbit, made up of both fat and orbital muscles. In the case of muscles, the connective tissue is condensed around the perimysium and emits septa into the muscle fibers, resulting in the endomysium. This is the reason we find fibroblasts within the muscle and fat. Although it is not an actual pathology of muscle or normal adipocytes. So in the orbit there are fibroblasts. They express the thyroid receptor, thyroid stimulating hormone receptor antigen, and they are present along the perimysium, which sends septa inside, forming the endomysium. So they are found there also. Anti-thyroid stimulating hormone receptor antibodies are present in almost 100% of cases. Elevated expression of thyroid stimulating hormone receptor transcription levels has been observed in normal tissue samples from OT cases compared to control groups. It has been found in vitro that the expression of thyroid stimulating hormone receptor proteins parallels the differentiation of fibroblasts into pre-adipocytes and interleukin 6. Fibroblast activation involves the release of cytokines which cause T cells to be attracted onto the orbit, releasing more inflammatory mediators and creating a vicious circle with interleukin 6 attracting B lymphocytes and sustaining inflammation. So there is differentiation of fibroblasts into pre-adipocytes and interleukin 6. Now there is release of cytokines by these activated fibroblasts which recruit T cells into the orbit. Again, these activated T cells, they're gonna secrete inflammatory mediators and they create a vicious circle with interleukin 6 attracting B lymphocytes and sustaining inflammation. So there are T lymphocytes and B lymphocytes too. In thyroid orbitopathy, the volume of the extraocular muscles and the retroocular connective and adipose tissue increases. So there is increase in retroocular connective tissue and adipose tissue, that is fat and connective tissue. Fat being the part of the connective tissue itself. This happens before the inflammatory cascade involving CD4 lymphocytes, macrophage B lymphocytes is initiated and the secondary deposition of hydrophilic glycosaminoglycans occurs. Particularly chondroitin sulfate and hyaluronic acid. Glycosaminoglycans, chondroitin sulfate, hyaluronic acid are deposited. These compounds have high molecular weight and high osmotic power and thus generate a prominent edema that impedes blood circulation, which together with an inflammatory state generates an ischemic environment. Fibroblasts in low oxygen conditions or in the presence of insulin-like growth factor 1 IGF-1, which is also present in the inflammatory cascade, increase the synthesis of collagen and hyaluronic acid, thus aggravating the situation. It has been suggested that negative influence of smoking on thyroid orbitopathy is due, among other things, to the lower blood oxygen levels produced. Orbital fibroblasts, unlike other types, appear to originate from the neural crest cells and possess a high degree of phenotypic plasticity. So orbital fibroblasts, their origin is neural crest cells. Neural crest cells. Orbital fibroblasts, they originate from neural crest cells, possess a high degree of phenotypic plasticity. A feature of orbital fibroblasts is the possible differentiation into adipocytes, and this adipogenesis generates an increased orbital content, an inflammatory hypertrophy of fat reversible and a true fat hyperplasia irreversible. When there is fat hypertrophy, it can be reversed, but if there is fat hyperplasia, that becomes irreversible condition. The formation of new fat in the adipose and connective tissues of the orbit is shown by an increase of mRNA and mRNA of adipocytes related genes. The formation of new fat in the adipose and connective tissues of the orbit is shown by an increase of the mRNA of adipocyte-related genes, including angiogenic inducers, followed by an increase of PPRA gamma, pre-adipocyte factor 1, adiponectin, leptin, and steroid coenzyme A desaturase. Steroid. In vitro ordinary fibroblasts differentiate into mature adipocytes when treated with rosiglitazone, a PPRA gamma agonist. This must be taken into account when it comes to treating Graves' disease in type 2 diabetics because it can increase thyroid orbitopathy protrusion. So what happens? Consider a case that is a patient with diabetes mellitus and TO, that is thyroid orbitopathy here. And if we give rosiglitazone as anti-diabetic medication in such patient, it can worsen thyroid orbitopathy and worsen the exophthalmos because this rosiglitazone is a PPRA gamma agonist, and these fibroblasts differentiate into mature adipocytes when these are treated with rosiglitazone. When the diabetic is treated with rosiglitazone in thyroid orbitopathy, these fibroblasts, they differentiate into mature adipocytes because rosiglitazone is a PPRA gamma agonist. So this must be taken into account when it comes to treating Graves' disease in type 2 diabetics because it can increase thyroid orbitopathy protrusion. If inflammation is not treated promptly, it becomes chronic, allowing fibroblasts to proliferate and synthesize collagen and fibrosis components in inflamed tissue, which will certainly hinder treatment. Intense inflammation, swelling, and adipogenesis lead to increased orbital muscle and fat tissue. These, together with the development of fibrosis, represent the four mechanisms producing all the signs and symptoms known in the clinical presentation of thyroid orbitopathy. Edema of the muscle fibers and lymphoplasmacytic infiltration in the picture. B. Inflammatory infiltrate between the muscle fibers and lymphoplasmacytic. C. Inflammatory infiltrate between muscle fibers and fat and diffuse fibrosis. D. Endomysial fibrosis between the muscle fibers, mesentericome growth in the center, HE, mesentericome. This pathogenic hypothesis is influenced hypothesis. This pathogenic hypothesis is influenced by other risk factors such as genetics. As in other autoimmune diseases, there is some association with certain HLA haplotypes. 30% of cases have a positive family history. Smoking. There is a positive correlation between the incidence and gravity of thyroid orbitopathy and exposure to smoke. We can consider this the main risk factor, and it is very important for the physician to emphasize the importance of stopping smoking. 6. Thyroid orbitopathy is more common in women, although cases in men are usually more serious. Age of onset in women is between 25 and 60, while for men it is between 30 and 65, or difference, delay of 5 years. Previous treatments. Patients treated with radioactive iodine in the active inflammatory phase are more prone to developing or worsening thyroid orbitopathy, 70% within 1 year. For those treated in non-active phase, the percentage of patients worsening increases by only 5%. So if we treat patients with radioactive iodine in active inflammatory stage or phase, then worsening of the symptoms or recurrence is of thyroid orbitopathy, it is 70% within an year. And if the patients are treated in non-active phase, the chance of the recurrence or worsening is around 5%. So it is safe to treat these patients with radioactive iodine in non-inflammatory phase. Anti-thyroid stimulating hormone receptor autoantibodies, high titers, correlate with more severe cases. So if symptoms are severe, it is proportional to the titers of thyroid stimulating hormone receptor autoantibodies, that is TSHR autoantibodies, or thyroid receptor and autoantibodies, TRAB or TSHRAB. So let us see some pronunciations. Agonist or agonist, that's the one thing. Then adipocytes or adipocytes. So we'll see that. Hormones. So what's the pathogenesis of it? These orbital fibroblasts, they express this thyroid stimulating hormone receptor antigen, and in Graves' disease especially, there is thyroid receptor antibodies, thyroid stimulating hormone receptor antibodies, TSHR or TRAB. So these antibodies, they combine with these receptors or antigens on fibroblasts in the orbit, and what they do, they bring about the maturation of fibroblasts into adipocytes. In that process, they secrete various inflammatory factors and cytokines, and they recruit many lymphocytes. First T lymphocytes, then T lymphocytes, they recruit B lymphocytes and macrophages, we'll see. Then some angiogenic factors. So when there is hypertrophy of fibroblasts, adipocytes, it is reversible. But when there is hyperplasia of adipocytes and the muscles, hyperplasia of this connective tissue, fibroblasts or adipocytes, it becomes the disease, the symptoms, signs, they become irreversible, especially this exophthalmos, proptosis. And in thyroid, what happens? These thyroid stimulating hormone receptor antibodies, they combine with thyroid stimulating hormone receptors expressed by the thyrocytes, and they activate them, and it leads to increase in the synthesis of thyroxine. But in orbit, it ends up activating these fibroblasts and inflammation and angiogenesis. That leads to hypertrophy and hyperplasia later on. First hypertrophy, first fat, and then muscles. So that was about the pathogenesis. Pathogenesis or pathogenesis? Obviously pathogenesis, adipocytes or adipocytes. Pathology, pathogenesis, I think we'll see. So pronunciations are like this. It is pathology, and pathogenic, then pathophysiology, then genetic, then phenotype, then phenotypic, 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 pic, phenotypic, phenotypic, pic. Actually, it's like a fuck. It's not fic. It's fuck. Phenotypic, phenotypic. Then it's women. It's not woman. It's women. V-man, man and V. Women. What else? Adipocytes. Adipocytes. It's British. Adipocyte is British, and adipocyte is American. So it's fine. So that was all about the pronunciations from all these 2.5 pages. Next part will be on clinical examination, symptoms and signs.